Yeah, it's working.
Right, welcome everybody who might be watching us on YouTube. This is the Healthwatch Coventry Steering Group meeting for October 2022. This is a meeting of the people who are volunteers and representatives of voluntary and community groups who oversee the work of Healthwatch Coventry. So I'm now going to pass on to our chair for today, who is Ed Devane.
Yes, welcome everybody to this October meeting. I'm standing in for Stuart Linnell today as the chair of the meeting, which is taking place live online owing to the resurgence of flu and COVID. So I'm just going to follow on now to the agenda, and our first item will be declarations of interest. So I'll start these. I am a policy advisor at the Department of Health and Social Care. However, I attend these meetings not in that role, but as a volunteer for Healthwatch. Any other declarations from the group? No. Okay, so I will continue on to our next item, which is the previous meeting's minutes, for which I sent apologies. We're a bit light on the ground for our last meeting, owing to the summer holidays perhaps. So please can those who attended confirm they're happy with the accuracy of these minutes? Yep, I can see some nodding as I cycle through faces. Excellent. Okay. Our next item then will be a presentation by Rose Ewins, who is the Comms and Engagement Lead for the Integrated Care Board in Coventry. Has Rose been able to join the meeting yet, or is she waiting in the lobby?
I'm here. I'm trying to unmute. I think
hello, Rose. Welcome.
Nice to see you. I've got two items on the agenda, and Zoom decided to completely redo itself. So I'm doing the ICP first.
Yep.
Fabulous. I've got a presentation, and since we've moved to Zoom again, should I try and share? Right. Let's see how this goes. How are we doing? Something's happened. Can you see the presentation?
Yes.
Okay.
Yeah.
I'm doing that. I'm going to try now to pop it onto full screen. Are we good?
Yeah.
Sorry, I've actually got a degree in computer science. You wouldn't think it, would you? In the presentation. So, just going to talk to you today about ICP, the Integrated Care Partnership, and what we're working on the strategy. I thought I'm going to rattle through the first couple of slides, but I haven't been to chat to you guys for a while, and I know you love looking at the diagrams that I make about how the system fits together. So I thought I'd just rattle through a kind of very, very brief reminder of where we were last time we talked. So, integrated care. We've talked about the importance of integrated care. I know that we hear a lot from you about the importance of joining up services, of working better together. So just wanted to highlight this is what it's all about. You know, when we talk about health and care strategies, this one specifically is about how integration will make it better. So we'll plan and coordinate those services, make sure everyone's as possible. And it's a really broad view of what keeps us happy and healthy. So I know you'll know the King's Fund model, of course, and then you've got the Core 20+5 as well. So all these different ways of looking at how we're keeping people happy and healthy. So as we became an ICB, have I talked to you since we became an ICB? I've been here since July. Brilliant. Okay, so again, I will go very quickly through this then. These are the 4 aims. They've been adopted across the ICS. They are the national aims as well. We want to improve those outcomes in population health and care, tackle inequalities, productivity and value for money, but also supporting that broader socio-economic development as part of this sort of integration work. And again, I don't propose to take you through the whole vision, but the important bit and the bit we're basing everything on is we're enabling Coventry and Warwickshire to start well, live well, age well, promote independence and put people at the heart of everything we do. That remains as we've moved from Health and Care Partnership, CCG world, to ICS, ICB, ICP world. That vision remains the same. That's still what we want to do. So I just wanted to kind of ground it in that. Back to the diagram, because we all love a diagram. It might be better on Zoom because we can see it a little bit better. But again, I think I just wanted to know the integrated difference between the Integrated Care Board and the Integrated Care Partnership and the Integrated Care System, because there are a lot of integrated care words and they get used pretty much interchangeably sometimes, but they are all very different things. So I just thought a 2-second recap on the Integrated Care Board is what the CCG transformed into. We're the organisation, we do the doing, we do the planning of health and care across Coventry and Warwickshire. The partnership, the Integrated Care Partnership, it has a wider remit. It is more of the equivalent of a health and wellbeing board. It's not an organisation by itself. So I think that's really important to note, that where the Integrated Care Partnership is responsible for is actually developing that integrated care strategy, which I'm going to talk to you about today. So I just wanted to recontextualise that. The diagram hasn't changed from what you've seen before. You've still got you guys up there from public review and scrutiny, but I just wanted to kind of remind everybody what the ICB and the ICP are, because I think get quite a lot of questions. The integrated care system itself it's almost more of a concept. It's the wrapper through which we deliver all of our work. So the integrated care system is everybody in the health and care system. So what have we done since the 1st of July? And again, just wanted to touch on that really quickly. The ICB board, we've got 4 non-executive members, partner members of primary medical services. We're looking at really making sure those aims of the ICS come through everything. And we're looking at that board development. So the board is made up, and I think that's always the difference between where the ICB and the CCG is. Particularly, it's about that integration. So on the board, we have representatives from the providers, we have representatives from local authority, all making decisions together, which is a really important change through the Health and Social Care Act. We've then got what the Integrated Care Partnerships met, talked about the admission and alignment. The deputy chairs the Integrated Care Partnership are the Health and Wellbeing Board chairs, so that's really important. Again, it is all linked up. It's not nothing. This is meant to be a replacement for anything. It's just meant to be that Coventry and Warwickshire link. We're still evolving the membership. We've needed to start with something, but we're keen for that to expand. So we've already got housing on there, but we're going to look at some of the different areas in which we can further expand that membership to make sure that it really is across all the wider determinants of health as well. And it's really important. So then you've got the Integrated Health and Wellbeing Forum, which was previously the PLACE Forum. So they're around as well, making sure that the voice of the health and wellbeing boards are still very much a key part of what we do. So why am I telling you all this, other than, like to keep people updated? I've talked about vision. We need to sort of deliver on that, and we need to detail how we're going to deliver on that vision to sort of help people start well, live well, age well. So by April 2023, we're going to have developed an integrated care strategy, and that's the bit the integrated care partnership is leading on. And that's going to be built from the existing Coventry and Warwickshire health and wellbeing strategies. And we will also, following that, have a joint forward plan which outlines how we're going to address the aims of the integrated care strategy. So it's 2 stages for one document, really. We're just calling them slightly different things. So the Integrated Care Board holds the responsibility for the joint forward plan, and the Integrated Care Partnership will set that strategy with the input of it from the health and wellbeing strategies that are already in place. Should I stop there if there's any immediate questions on the structure of this, and then I'll come on to what we're actually doing? No, you're good? Fabulous. Oh. Okay, that's fab. So I just wanted to, I know we've talked about most of this before, but I thought just best to set the scene and get that background in place. So what we are doing, what I've come to sort of talk today, is we are doing a process of engagement. We are building on what's already in place. And I think that's really important. This isn't a strategy where we're going away to start from scratch, think about how we could do it. That work has been done through our 2 health and wellbeing strategies, and through lots and lots of other engagement that's taken place already. And I think that's probably one of the most important things to reference, because the timeframes are very short on this. April 2023 is an ambitious timeframe. It is nationally set. We've got no control over that, and we do need, as going into the new financial year, to have a strategy and plan. So it's an appropriate timeline. But I think it's reinforcing that, as I say on the slide, the involvement of community stakeholders is absolutely vital to make sure we're on the right track. But it's not a case of we're going out and doing that bit of blue sky thinking about what should go in the strategy, because we've got a lot of that information already. So our approach, which I've talked about a little bit already, but we're going to try and do it as one document. The vast majority of people we speak to aren't going to see the nuances between the strategy and the plan. This is just what we're going to do. And I think that's really important, that we allow people to feed into all elements of that. We've got we're looking at developing focus areas and enablers based on what we already know, and from some of the engagement work that we've gone out. So we've been going out since August, talking to lots of different groups of people, just to sense check, what's changed since COVID, what are our priorities, what should we be looking at? And that's what I'll come on to your input on that in a minute. Really keen, when we talk about this strategy, we're not talking about creating something that's 300 pages long. Short and concise, built on what we've already got, and I keep saying that, but it's really important. And then we'll talk about one of the areas of focus we think in practice, informed by engagement, to bring it to life. So again, I've talked a lot about the fact that we've already done some of the engagement, that it's ongoing, which I think nicely brings me on to some of the bits we've heard so far. I don't think anything you see on here, I'll share these slides afterwards, of course, but I don't see anything on here that's going to come to a surprise to anyone in the room. We've not been hearing new things. What I would probably observe that I've heard in the engagement that's different compared to the previous engagement that I've done is that COVID has potentially put a sense of intensity on that we didn't have. So people are not people are not in the same state as before COVID. People are generally struggling more to access services. They are in worse health themselves. And I think that's something you will have reflected. I know you've reflected back to me already from the engagement that you do. So that would be my reflection. I was seeing an amplification of issues as opposed to new issues coming up. So I just wanted to pop these up. So the engagement is ongoing and will continue as we write the strategy to be fed into what we hear, what we're writing, to make sure that it's informed. Things that are more relevant to the doing, to the plan, will be fed into the plan as well. So all this engagement is being done specifically for that purpose. So what I wanted to kind of ask, firstly, if there's any questions on the process or the strategy, but I'd really like to hear from you as people that talk out in the community, as you have that information. Ruth shared brilliantly lots of the engagement that's been done already, and that's been used to feed in. So I've heard a lot of the feedback that you've already had as Healthwatch has already been fed into that. But I did want to kind of just open that discussion and give the opportunity, either from a personal perspective or from a sort of feedback from community's perspective. Sort of these two key questions is: what matters most, what really has to be in this strategy, and what barriers do residents face in accessing care? What are the real barriers that we absolutely need to address through this? So I'll stop if you're okay to.
Okay, thank you for that, Rose. While I'm waiting for the hands to shoot up and respond to those questions, I'm going to use chair's privilege and just jump in with some myself. So number one, I think for me would be, what about the cost of living crisis? I mean, yeah, COVID's been on everybody's minds for the past couple of years, but this is front and center of if you're thinking about the wider determinants of health. So yeah, has that come up in the recent engagement you've been doing? And on top of that, I think it's you know, thinking about your short deadline to turn this around, it's good to work with the existing health and well-being strategies that you mentioned. But what have you actually managed to change with this new strategy? Yeah. So those would be my two questions, and then I'll pass on to Ruth.
So I'll pick up cost of living first. Cost of living, yes, it has come up, but I would say it has come up what I'm hearing far more about was access. At the moment, when we're talking about health and care, I think we certainly see it as one of the biggest risks I'm concerned about in terms of condition of people. You know, if you're not eating right, if you're not managing to keep your house warm because you can't afford to, then your health is going to be in worse condition. So I think there is an impact there. And we absolutely recognise that, and it's really important to hold that in. I haven't heard people specifically talking about that in the engagement that we've done so far as something that, and maybe that's because they're thinking more about specific services, but I think, yes, it's not come up from individual groups at this point in terms of what should be within the strategy, possibly because people are thinking it's out of scope. But I would say very much that this is something that has to be in the strategy and something that we're aware of, and we've got those concerns. What was your other question? I'm really sorry. I got taken up by.
Sorry, it was what has changed? You said you're working with the existing health and well-being strategies, and you have a short deadline. But what's actually changing in this updated document?
So I think in terms of it is a Coventry and Warwickshire document. So it is looking a little bit at that wider context. There's a lot of synergy between the two health and wellbeing strategies, and that's great because that gives us a foundation. So it is really more of a bringing together of what we have rather than going out and developing new. But what we will be looking at is key areas of focus, excuse me, for the ICB, for the ICS. And some of the things that we're looking at could be children, best start in life, children and young people, ensuring people who almost solving the problem for 10, 20 years down the line. And I think that's something that's come up as being a focus. That's one of the things the Health and Wellbeing Board want to focus on. But I think it's more about looking at those specific areas we can fix as health and care. And then the plan will be how are we going to deliver that. Does that kind of answer the question?
Yes, that does. Thank you. Yeah, I'm surprised to hear that the cost of living crisis hasn't been coming up more. But yeah, maybe that's to do with the groups you're surveying as well, possibly.
So I think when we talk about what matters most to the health and wellbeing, we're getting more specific maybe. I mean, I'm happy to, I think I'll share with Ruth anyway, and I'd be more than happy for the feedback so far to be shared at a later date. I think it's possibly how people are thinking about it, and they're thinking about, well, what could you solve within health and care? And no one's going to be surprised that some people have mentioned GP access. So I think in terms of that, maybe people are telling us more about those than the why. I think it confuses everything at the moment.
Okay. Well, thank you. So I'll pass on to Ruth to ask some questions, and then David, who I've seen has put his hand up as well.
Thanks, Ed, and thanks, Rose. Three things. So the first is just a practical question. If you could just flesh out the timeline a little bit. I don't know if it's shifted, because I think the timeline that I'd heard about was this had to be done by December.
Yes. We need a first draft of the strategy by December. So we can't write a plan to deliver the strategy until the strategy has been written. So although the finalised documents will be for April 23, we will have a first draft submitted to HA. I think it is December the 14th. We'll have that first draft, which still will be draft. We can still add more in, but I think in order to write a plan that responds to the strategy, we've staged it like that. So that's where the December deadline.
Okay, that's good. That's as I understand it. So not just checking it hasn't shifted. Okay. So I'll just say the two questions. So one of these is on behalf of Stuart, who unfortunately has been called away and he can't be at the meeting today. So you've mentioned GP services, GP access. So Stuart would definitely be talking about access to GP services for Coventry residents if he was at the meeting at the moment. So key as the sort of starting point, the gatekeepers, if you like, in terms of access to other health services. And it's not everybody in Coventry that is experiencing issues around it. It is varied depending on which is your GP practice, but definitely a significant increase, as you've alluded to, in terms of the issues that people are finding actually accessing that primary health care. And then one of the concerns that we have from Healthwatch is people who've kind of given up trying as well, really, who are kind of now off the radar. And my point is, I suppose, because we're Healthwatch Coventry, we're focused on Coventry, we understand Coventry communities and neighbourhoods and issues people are experiencing here. I just wonder how easy it is to kind of come up with a strategy which is so overarching across Coventry and Warwickshire, really, and how sort of more inequalities threads could be picked up in that, because people's experiences might be quite different because of where they live or because of other factors in terms of their community. And sometimes that kind of gets a bit brushed over when things are looked at in that wider perspective. So that was how I was wondering how that might be factored in, really, because yes, you can have conversations with this group of people, with that group of people, but not everybody's in the conversation, are they? They never can be. But there must be other data and other work that is also going on under the umbrella of the ICB around the kind of inequalities agenda and those sorts of things.
Sorry, so I'll pick that one up. In terms of the inequalities, absolutely. Even I would say, even in Coventry, we couldn't apply a single inequality strategy about Coventry, because it is absolutely different between communities, whether it's geographical or faith basis. Very, very different. So I think inequalities is absolutely a theme, and tackling health inequalities is one of the key aims, but it will also be a theme running through this, and I believe one of the focus areas that we will be looking at. It would be where, we've got the core 20+5, we have the inequality strategy already, which I believe you've seen. If not, I'll share it with you, I'm fairly sure it's come to you already. But it will be about how we deliver on that inequality strategy. And I think the core 20+5 is really, really good support for that, in that you've got those 20% most deprived areas, you've got the plus areas that we've identified, some for Coventry, some for Warwickshire, and then you've got those 5 key areas, and like maternity, people with adult health checks for people with SMI, so those specifics as well. So that would be how we would look at the inequalities. But I think it's a good point to reference back and to sort of put into the feedback that we need to be clear that one size fits nobody, really.
Okay, David, do you want to go next?
Thanks, Ed. Good morning, Rose. I think integrated care system, integrated care board, I think it should have a great start for that first word, integrated, because what a lot of people find out in reality is that at the moment, despite the fact that we're told that your records can be accessed by people by going onto the computer, and people can share information, whether it's the hospital or the GP or whatever. The actual calls that I hear from are people saying it's not as well integrated as it should have been. And I think that's something that you will be able to do. It's not a magic wand. You're not going to be able to do it straight away.
A target, that's what they think they should go. It's what they should get based on their GCSE results. Then what one's got better isn't going to be. That's too complicated.
I'm not quite sure who's talking now.
I think it's Sam who needs to mute.
All right. So I couldn't see Rose's lips moving, so I assumed it wasn't her.
I'll talk about GCSE results, I promise.
But I mean, the greater problem, and I'm not a great one for anecdotal, but as I was saying to some of the steering group during the break, my wife's just spent 18 days in hospital in UHCW and has now been discharged and receiving help from adult social care. That sometimes you realize that the money is absolutely lacking everywhere you go. So first of all, it was suggested by occupational therapists that she would be best off going to rehab in a retirement home to get physio there. And then we found out through doing a bit of investigating that would she get intensive physio? No, it probably would be once or twice a week. So she would be stuck in a retirement home, probably getting worse, not better. Unfortunately, another occupational therapist said, somehow or other, you've got to get her home. And this morning, she actually had a physio come here who admitted that she goes into retirement homes, but she says they cannot do what is on the tin, that they have not got enough staff to be able to give people who are supposed to be having re-enablement, I think the word is now, in a retirement home. They can't give them anything like the service that they should be able to. So that's the other barrier that all of us needing any support face, that there's a lack of GPs, there's a lack of nurses, there's a lack of hospital doctors. When it comes to domiciliary care, it is absolutely horrendous. Bridget had care help. I think we've had about 16 different people here in 3 weeks, none of whom we could even find out their names, let alone anymore. And again, sometimes they just didn't turn up at all. So you can't do much about that. Perhaps eventually we'll get a Secretary of State who has a bit more ambition than someone being able to see a GP within 2 weeks. But the main one I'm talking about is the barrier that people face when the different departments are not talking to each other.
Yeah. That's brilliant, thank you. And I think those are really important points. I hope the wife feels that is better soon.
I'm conscious of our time, and you still have another update to do, I think, on dermatology, Rose. But yeah, before we go on to that, I just want to ask one more question, and maybe you could give like a quick answer. How is this going to be implemented? How is it going to be delivered? How are we going to hold you to account? Is there going to be any kind of commitments or milestones that you're looking to achieve, or is it too early to say?
There will be a plan. So we'll have the strategy is the first part, as I said, between January and March. We're developing the actual plan, which will be a full delivery plan. So that's the joint, that we're calling it the joint forward plan, although I know the council calls something different, the joint forward plan. So I appreciate this. So it will be the integrated care 5-year plan. And it'll be responding to the NHS long-term plan. So that there will be a full plan, absolutely. We'll bring that back as it develops. As soon as I've got a working strategy, I'm going to come back anyway, hopefully. So we'll keep you informed. But that's, as I say, from April, we'll have the strategy, we'll have that plan, and we will have what we'll be delivering in year 1.
Excellent. Rose, could you just clarify for people who's responsible for that plan? So where the accountability sits.
Integrated Care Board. The Integrated Care Board are about the delivery. The partnership are about the strategy. And I'm going to be really cheeky just while I've got the mic and do one more thing, is that the next one, we're still doing ongoing engagement. So if there are, I know Simon's been in a lot of contact with lots of people setting up opportunities. If there are other opportunities that you think we should be at that you've not heard from us, give us a shout. We'd love to come and talk to more people. We're also going to be doing a survey, an online survey, to complement all of the face-to-face work that we're doing, and I will hopefully be able to share that next week. So would really, really appreciate everyone's support getting that out as far and wide as we can.
Yeah, we'll be happy to share that, Rose. What's the deadline for people to respond to it?
It's going to depend when I manage to get the survey out.
Okay, you're right. It takes a while for things to cascade through and get communicated out to people.
We want to give people 4 weeks to respond, because a lot of the information, as I say, if it's not for the strategy, it goes into the plan. So although we've got that December initial deadline, we still will be able to feedback more. You're going to have to now bear with me while I work out how to not share. Oh, okay. Back on. Okay. So do you want me to just jump straight onto dermatology?
Yes, if you wouldn't mind. Thank you.
That's absolutely fine. I'm sorry. So I think a stakeholder update came around yesterday. So Ruth, if you haven't seen that, this will all be sort of in text as well. We can forward that around if it hasn't been. But I just wanted to briefly touch on what we are doing with dermatology, which is we've identified that there is a disparity between Coventry and Rugby and Warwickshire North and South Warwickshire based on sort of historic commissioning decisions. But in North Warwickshire and South Warwickshire, there is a community dermatology service. And looking at the definition of community facilities from BAD, the British Association of Dermatologists, actually we don't have anything in Rugby or in Coventry that meets that definition, which is settings describe consultant-led services in a range of settings such as healthcare centres, GP practices and community hospitals where clinical assessment, treatment and minor surgery and advice can be delivered for a variety of non-urgent skin conditions. This is all in the update, so you should see that anyway. So what we are doing is we're trying to put in place one model of community dermatology services. So this is additional for Coventry. This isn't replacing, this isn't changing around, this is new. So at the moment in Coventry, GPs will refer patients with minor dermatological conditions to UHCW, and then they can be seen at the City of Coventry or on the Walsgrave site, on the main UHCW site. So, but technically those don't really meet the definition of community services. So what we're looking to do is put in 3 new community services in Coventry. So to address waiting lists and to ensure people don't have to travel as much as possible, they will be more community based. So we're going to put those services in, and hopefully that will really improve things for patients. What we are doing is to inform that procurement. We've got a survey that's going out for people, which again, I think it's linked in the thing. If you can help us promote, we'd really appreciate it. It's keen to hear from lots of different people. So what the information in that survey will be used to do is, Zoom's gone funny here. What it will be used to do is to inform the procurement process. So when we go out and ask, what's important to people, it'll help us to shape the contract to ensure that that's the right thing. And then when we're selecting a potential provider, it will help us to look through that and understand that it's rooted in what people want. So I think that is the basis of it. Happy to take questions on it. Ruth, have you had the stakeholder update already?
Yeah, the stakeholder update came yesterday afternoon, so I'll forward it round to steering group members. I just wanted to check that the deadline for the online survey completion is the 24th of October. Right. On the email that we've had, which is a week away. Yeah, it should be the 28th, so apologies, we'll send a update on that. So 28th of October. Yeah. So it's still quite tight. It is. I think we are. We just want people. We've got a lot. It's going out through a lot of the patient lists of people who have received services. Being supported by that. So it should be going out to people who have received services. And I understand it's a short time frame. It's partly driven by the procurement, and again based on what people have already told us about the services. It just means in terms of cascading information through organisations through ours, it's very unlikely to kind of work in that time frame really. So all we can really do is post it on our website and do some posts on social media. So it's not really going to hit many people through those methods.
No, I do understand that, and we're working and cascading it ourselves as well. I think it's just asking for any, if you can push on social media, that would be fabulous.
Yeah.
Really.
So I mean, in terms of the time frames, then, because that's been set as very short, is there a reason for that? What's happening?
I think we're keen to go ahead with getting the services in place. They are brand new services. It's not a sort of change of services. It is about adding in new. So it's just doing that sort of it's doing that sort of sense check. If there are things that people want to tell us about how we should be looking at those community services, would be based on this is based on the sort of model of community defined services. So in terms of the type of service, we're not basing it, we're not devising it out of scratch. This is something actually that's also worked really, really well in Warwickshire. So it's that the model is tested. It's more about sort of just understanding if there's specifics around Coventry that people want to feed back to us, or what's really important to them about dermatology services that maybe wouldn't have come up in Warwickshire. So it's a sort of a sense check for us.
Okay, I have a question, if I may. And just to clarify, you're saying this is an addition of services, but I just want to check, actually, is this the dermatology services are being moved into the community? Is it a reprioritization of services? Are the hospital services actually being cut back, or is it actually an addition?
We don't have those sort of services that meet these, so it's more capacity to meet that across the area. Does that make sense? It's adding the capacity so people can go to different places and receive the services.
Okay, so there's no changes to the services, for instance, at the Walsgrave site? No,
people would still, I've chosen to say, people would still be able to if they want to go to Walsgrave, they can still go to Walsgrave.
Okay. Well, unless there's any other questions from the group, I can't see any other hands. I'll thank you, Rose. That was a very comprehensive presentation, and very informative as always. Feel free to stay for the rest of the meeting or drop off now.
I've got to rush off, but thank you, everyone. It's lovely to see everyone again.
Right.
Take care. Bye.
Okay. So moving on to the next item on the agenda is some reports about our recent activity as a Healthwatch, and I think Ruth is actually going to speak to paper 1 that's listed on our agenda about recent.
Okay, so I think we could probably mainly take it as read, Ed. So I've added a summary page to the usual activity report. So those are the kind of highlights since the last steering group meeting in terms of the things that we have been focusing on in the staff team to move forward. So you also have paper 2, which is a summary of the small grants which we are awarding to the groups that applied through the simple application process that we ran a little bit earlier in the year. So those projects run on slightly different timelines. They're different pieces of work targeting different members of the local community. So some of them will complete before others, and some of those groups are asking for a bit more support from us in terms of the method, in particular, how to ask the right questions in the right way, those sorts of things. So that's the kind of input that we'll be giving to the groups. So it's a bit experimental. It's a different way of trying to do things, but hopefully it will mean that we will hear some views and some experiences from people that we wouldn't have done otherwise. That's the idea behind it. So if anybody's got any questions or if anything's not clear, I shall answer.
Yeah, I think I'll just go ahead and ask a question. I'm really interested in these small grants, and I think it was mentioned at the last meeting that I missed. But I just think this sounds like incredible work, and in terms of the things you're talking about in the good engagement charter, You're giving people, responsibility and working with the groups that are already out there in the community, and using, the kind of leadership that's there already. I think that's definitely the right approach. So I was just wondering if you could say some more about them for the information of the group. And then secondly, I think this is something maybe as a Healthwatch that potentially we're doing like really nationally leading work on. And if there's some way to, bring together the results and kind of spotlight it in terms of like a publication or some kind of output, because I think it's really worthwhile, and it would be good to get some recognition from it.
Well, thank you for your confidence. It's fairly early days at the moment, so I've got some groups that I need to catch up on because I've been not at work because I was ill. So it's different approaches that different groups are taking, really. So it's combinations of surveys, interviews, and discussion groups. So we've got the Deaf Association who are doing a piece of work with the deaf community, so people who speak BSL, for example. So that would be really difficult for us to do from a Healthwatch point of view without their input, wouldn't it? So in terms of the application process and what we asked, we did leave it quite open for groups to kind of come forward with their ideas. I think some of the groups possibly might need a little bit more help than was anticipated to start with. Is anything new in the world of Healthwatch? I don't know. Healthwatch is nearly 10 years old, and there's 151 around because there are other Healthwatch who have done sort of pieces of work with funding through other organisations. So it's not something I've invented. And earlier in our history, we did commission out some bits of work, possibly right at the point where Healthwatch was starting and the previous organisation was ending. FWT did a piece of work around maternity and breastfeeding support, for example, which was fed back in. So I think it's going to be really interesting, and I'll definitely keep you informed as to how things are going, so we can pick it up again at the next meeting in December.
Brilliant, thank you. And yeah, I was particularly looking at the project with refugees. I think as a city, Coventry definitely leads the way in helping resettle people, and it's really important. Those people are often ignored by the methodologies that we might normally use, or we find them harder to reach, that term's used. So I think taking a different approach is definitely something worth doing, and I look forward to hearing the results. Okay, so I'm going to move on to the next item, which I think is an issue log that Healthwatch England have advised on. So
yeah, so this is for information. So I send these to each steering group meeting. They produce these monthly. So it's a way of kind of communicating the stuff that is on their list. So it's coded. So there's pieces of work that they're actively working on, things that they're obviously still interested in because they've done some work on it recently, and then things that they're wanting to, I suppose, hear the lowdown on from local Healthwatch, so the information that we share with them. So that's the kind of national picture, because we're part of this Healthwatch network and hooked up to Healthwatch England, who have the job of working with NHS England and the Department of Health and the politicians in a way. So there's a new Secretary of State for Health in post, new ministers. It's been quite a period of change over recent months. So in terms of Healthwatch England's work, they've got relationships to build and influence to garner with a whole new set of people.
Yeah, and I think the priorities that Healthwatch England has set out there kind of reflect that. They're dealing with what the Secretary of State calls ABCs, Ds. There's 2 Ds, I think: doctors and dentists, ambulances, backlogs, care, and recruitment. So yeah, that's interesting to see. So if there's any comments on that, I don't think I see any hands. Any queries? No. Okay, well, in which case I'll move on to the reps reports. So yeah, any things that the reps wish to highlight from this? David's got his hand up, so I'll hand over to him now.
Thank you, Ed. It's really, you're taking over from me and doing an excellent job writing up the scrutiny board meeting reports. But one of the perennial things that I've been talking about for years and years with the adult social care is their lack of engagement. And on page 2, second paragraph, they give an excuse for lack of engagement. Traditionally, this work was done via a postal customer experience survey, but engagement was low. Since April 2022, there have been just 13 responses. And I just think in terms of what we would expect from an organization with, I think they have over 2,000 service users, 13 responses is just negligible, really. It's about like the 0.01% that voted for the current prime minister. And then it goes on to say in the next sentence, the adult social care stakeholder group was mentioned as another area of ongoing good engagement. Well, again, I'm sorry people have been on this group for a while, but you've heard me say that it's not a good example of good engagement because they have so few people attending the meetings. It's actually the last one that I reported on a bit further on in the paper. They did have 1 or 2 new faces, but they seem to be completely unable to get people on board. Maybe they've got the same problem as steering, but it is not right to say that it's an example of good ongoing engagement, because basically we have no input into the agenda. Those of us that do attend, I think of the 4 people that are regularly taking part, as against about 7 or 8 officers that are often on board. None of us are actually carers. We're there representing another organization like Healthwatch in my case. And you feel as if you're making comments which are maybe or maybe not worthwhile, but it's very much a tick box exercise. And I don't know what you felt from the report itself, Ed, whether you felt the engagement was given enough spotlight or not.
Yeah, I felt a bit like I couldn't challenge about this adult social care stakeholder group because I don't attend it as frequently as you do, David. But yeah, when it came up on these slides that there'd been just 13 responses to the existing surveys that are done on adult social care, I did think that was completely inadequate, as you say, due to the population of service users. Clearly, that's not representative, and it's not a good sample. And also in the meeting, it was suggested that in future, these kind of surveys might be done online or via a website. But councillors were very quick to point out, due to the population of service users who might already struggle to access and use technology, that was hardly an improved solution. So if I'm going to be fair to Pete Farhay and his team, I think they do struggle to know which approach to take. And as you mentioned, even we as a Healthwatch, you tend to get the same people responding to these kinds of things, don't you? So at that meeting, I was trying to hammer home the work that we've been doing, and that their methodology of engaging people was the problem, and they needed to come up with some new ideas, and that we were available to help them. And I was trying to hammer home that point. I'm not sure if you've got any other tips for me, but I'll definitely pass on your comments about the stakeholder group at the next scrutiny board meeting. And note that.
Thank you. I mean, just one observation. Yes, fair play. You know, a lot of people that are being currently cared for may be in very poor health, and the last thing they want to do is complete a survey. But a lot of those people, if not the majority, have informal carers who certainly would be able to make a contribution. Anyway, thanks, Ed. Good report. Carry on.
Just on those points, David, I mean, I suppose it's positive in a way that they flagged up that engagement was a challenge. And I think I absolutely agree with what Ed has kind of said at the meeting in terms of they need to have some different approaches and different methods. It is a client group which it's going to be harder for people to be able to give their feedback, isn't it? Because you don't actually receive those services unless you have a significant need. I
accept that.
So I mean, I don't know, Claire, because you're from the Carers Trust, so I don't know, because you would think that there would be a route for family carers and informal carers to perhaps be able to provide more feedback to the local authorities. Is the Carers Trust involved in anything?
My understanding is we're not involved in anything targeted specifically at the moment, but we would welcome that. And I made a note to get in touch with Rose about some of the bits that she was talking about as well. I noticed on one of the slides it mentions talking to unpaid carers, so somebody's obviously already raised that. But we have got our carers voice forums across Coventry and Warwickshire. We've just done a big piece of work with Warwickshire around the procurement of the new all-age carer wellbeing service. So we've done quite a lot of co-production and consultation with unpaid carers, and I know that because Coventry are undertaking some similar procurement work over the next 12 to 18 months, we were looking at doing similar. So we're more than happy to get involved, and I've got lots of people who would be
it does feel like something needs to be kind of built, doesn't it, really? And actually there must be something happening in other areas of the country, whether they're nearby, whether it's Warwickshire or some other place in the West Midlands, or where there perhaps might be some good practice examples to think about how to enable people to have a voice. I'm also thinking back to when we did a piece of work where we did interviews with people who were in receipt of domiciliary care home support a few years ago now, but I'm pretty sure, I'll look out the report, that one of the findings was that people were fearful of actually raising their experiences. And I'm sure we made a recommendation to the council that they needed to think about how they addressed that. So it was both in the context of people complaining around the standard of their care, but it was also, I think it could be linked to feeding back as well, because sometimes people don't see the two as distinct, do they? And that people were sort of really quite fearful about what that might mean, and the impact on their care, and what could be quite particular relationships with individual people, can't they, as well? So I think there is something there that needs to be thought about.
I was just going to add to that, one of the things that we've been finding in some of the conversations we've been having is some of that fear comes from some of the terminology as well around doing assessments and carers assessments, and people think it's an assessment of their ability to provide care rather than assessment of need. So I think there is that real fear of raising issues because people feel that could bring scrutiny to them in their caring role, which could lead to people thinking they're not managing. So that's something we're looking at with carers at the moment in terms of how we can change some of that to make people, or to support and help people to feel less fearful about doing that. So there's definitely a conversation to be had here, isn't there, in terms of trying to unpick some of these issues and barriers, and sort of thinking about how it can be done, and ultimately it does need resource to gather people's views and feedback of services. You can understand why organisations kind of reach for the online survey, can't you, in these challenged times? But I don't think it's meeting
meeting the need, is it? So, or providing anything that's useful. So, yeah.
Yeah, and I think this issue, specifically as it relates to social care, is not going to go away over winter. People are facing all kinds of pressures. There's issues with the social care workforce. Unpaid carers are not being covered by surveys. We need some kind of ways to get insights into the challenges they're facing if we're going to try and alleviate these circumstances. So yeah, it's something to keep an eye on and do some more thinking about, definitely. Okay, so just some other things. I might as well continue to give an update on other things that were covered at the Scrutiny Board 5. I just noticed that in their annual report, the council had noted that there'd been a really significant increase in safeguarding concerns. I think it was 36% increase compared to last year, and 82% increase on inquiries, which is the next stage after a concern is raised. However, Pete Fye was reassuring me that there'd been a dip during COVID. However, now that increase that we're seeing is well above pre-pandemic levels. So it might be something to keep an eye on as a health watch as well. David, I see you got your hand up.
Well, it's just a quick observation on this one. And again, I've talked over this with Pete Fahey in the past. I understand the premise that it's good if people are raising issues, far better than them thinking, no, we better not say anything. We don't want to rock the boat. But it must, and I've said this to them, there must come a point where if the number of safety concerns percentage-wise goes up that amount, that there are more problems. Now, maybe he's right. Maybe there were particular circumstances relating to it, but I don't know whether Ruth had got any comment on that. We've heard it from the hospital in the past as well, haven't we? That, we've got more reports. That's good. It means people are prepared to say, nurses, healthcare assistants or whatever, that something went wrong. But,
I don't have any more information, David. So,
no.
So one would hope that there is a breakdown somewhere of what those safeguarding inquiries, in particular, are kind of relating to, and that is being looked at. But I don't have that information. I mean, it's something that we could maybe request if that's something that steering group members felt that we should do, or maybe at a point in the future.
The problem I come across all the time is the fact that most people still think that domiciliary care is provided by the council. And of course it isn't. It's provided by private companies. And how closely they're monitored by adult social care, I have grave reservations about that. And what you get in reality, and again, my daughter is a district nurse who comes across people all the time working as domiciliary care assistants when she's visiting to deal with someone's ulcer or some other problem, is the very, very poor standard of care workers that are not wearing PPE, care workers that don't seem to understand the basics of hygiene. And that, I don't know whether the adult social care attitude on that is that, it's up to the companies to train them better and things like that. But nevertheless, there is a yawning gap there where again, and we've seen it here. We're pretty sure that we caught COVID off the care assistants because we had nobody else coming into the house. They did, when we stretched them to go back and get aprons on, but they often pulled down their masks because practically everyone had very poor standard of English, despite the fact that at a previous Healthwatch meeting we were told that all care people had to have the equivalent of GCSE grade C. They may have got that in a written paper, but no way have they got that standard in terms of speaking. So it's not good. Oh, I know maybe we were unlucky. Maybe there's a lot of people would say they had fantastic support from the care workers. But again, adult social care doesn't seem to really be aware of what's going on, I don't think. Sorry, I'll shut up.
Well, they won't be, because they're not getting the feedback from people. So I suppose that's the challenge, isn't it? So that, as you say, they don't run the services. They're putting out contracts, and they're not hands-on in those contracts. They would expect the companies to follow what is written in them and all of the provisions and the safeguards that are written in them. Now, clearly, it sounds that may not be happening from those anecdotal experiences, but obviously there's a lot of this care going on, isn't there, in the city, and there's different care agencies involved depending on where you are located in the city as well. So I know that that the City Council has removed contracts from some care agencies, and they're in the lead up to going out for the retendering exercise for domiciliary care, or home support as they call it in Coventry. So yes, actually this is a particularly good time to actually have some feedback, isn't it? But as we've been discussing, the mechanisms aren't there, or they're not working at the moment. So that's the bit that the attention needs to focus on.
Yeah, and I think that brings us quite nicely onto our next item, actually, which is another kind of social care surveillance in the form of the CQC reports, which have come out recently. So one of these covers a GP practice that was previously rated as requires improvement, and I think still is. Elsewhere, a care home which hasn't previously been inspected has been rated as inadequate, and mainly from what I've been through of these reports, these problems in care homes were related to a lack of managerial oversight. And yeah, it will be interesting to see if these kind of issues are reflected in our own programme of enter and view inspections that are arranged. So I'm not sure if you have any thing to add on that.
Well, the only thing to add is that it did come round slightly late in the day, but there has been another care home inspection report which Lizzie sent round to steering group members. So another care home which has now been rated as inadequate in Coventry, St Matthews, I'm thinking. So the CQC has been quite active visiting social care providers in Coventry. So this is the latest in a kind of sequence. They've also been inspecting home support agencies. So that's not necessarily the ones that the council commissions, because there are lots of those agencies that exist that people pay privately for home support services, and there's been some considerable issues with some of those as well. So yes, I think the management of services is always a key factor in CQC ratings and in the findings in reports. So the GP surgery, so that's Healthwatch Health team. So we had a number of conversations at this steering group last year. I think these started, and prior to the previous inspections that the CQC did of Healthwatch Health team, which is a large GP practice in the northeast of Coventry, and we had received a lot of negative feedback from patients, and were very active in making sure that the CCG at the time, the Clinical Commissioning Group, who was the commissioning organisation, and the CQC saw that feedback, and that we understood what was going to happen, because people were not, well, they were reporting to us in that feedback that they weren't able to access the services that they needed, and weren't in some instances getting their medication and things like that they needed. So the CQC has re-inspected, which is a part of the programme, because the GP practice had an action plan, So the rating for that GP surgery hasn't gone up, it's still the same. So the CQC will be going back again at some point. So some things have been addressed, and some things haven't, I guess, is what the report's in two parts now. The way that GP reports, you get like a short summary report, and then you've got like some data in a separate report, which is the interesting bit. So it's still obviously something for us to keep an eye on, and to continue to have conversations locally about, because that was a GP practice that used to have over 13,000 patients, so quite a significant size.
Okay, thank you for that background, Ruth. Another update is that the NHS 111 provider covering Coventry, the West Midlands Ambulance Service, will actually be winding up that service after the winter period and contracting it out to a firm which is based in Albury. So I think I saw that this story had been picked up by the local press, actually, and this company, which is based in Albury, will be opening a call centre closer to Coventry, but those plans are still being worked out. I think one thing to keep an eye on is that with the 111 service being moved, that this new company has up-to-date, data on people's addresses and things like that, and calls don't end up being passed around, which I think has been a problem with this service provider before when they've been working in the Northwest. I'm not sure if you've got anything else to add to that. Anybody else on the group?
No, so that's just the latest update that's come around from the ICB. So at the last meeting of the steering group, we'd had notification of the change. So it's actually an ICB elsewhere in the Midlands that manages the contract for NHS 111. So they were anticipating that this change would be happening by now. So essentially this communication is to say that it's going to take longer, with West Midlands Ambulance Service stopping the contract for reasons that haven't gone into the public domain.
Ed, could I just go back to the Melbourne House report?
Yes, go ahead.
Couple of things on it. Interesting, it says that they've got beds for 33 residents, but they actually had 12 in the building. Now, my guess is that's because they can't employ enough care assistants to cope with more than that. But the question I've got, I don't know whether Ruth knows the answer to this. It says in the report that there have been care safety issues since 2014. That's 8 years ago. So this has been cropping up for 8 years. I mean, at what point does the CQC say this can't go on any longer, we're closing you down? I mean, you've said about domiciliary care companies losing contracts, but surely, I mean, I'm personal on this now because you enter and view. I used to say years ago when I did it, I'm looking to see whether this would be a nice place for my mum or dad to go to. If I were doing it now, I'd be saying, is this a nice place for me to go to? As I said earlier, Bridget had a narrow escape. She could have ended up in re-enablement in a care home. But, you know, it is pretty desperate when, is the service safe, inadequate? Is the service well led, inadequate? And this place is still operating. And people are maybe today taking their mum, their dad, their aunt to Melbourne House.
It's been put in special measures by the CQC, David.
Yeah.
So if it's taking local authority and CCG placements, there is a group that meets, that the local authority convenes, which is responsible and discusses issues within care homes. So there's likely going to be what they call a placement stop, so where they won't place people within the service. I think I agree with your point, though. There are a number of services, it's not just care homes, where they've had a number of inspections over the years by the CQC, where issues have been flagged in one way or another. They've had action plans, maybe they've then improved, they've gone up a little bit, and then it goes back down again. And it's the same services quite often, and it does seem to take quite a long time for it to reach the point where it's kind of concluded that this service it shouldn't carry on, or it can't carry on for whatever way. There have been some. So there was a care home on Westminster Road, for example, which we've talked about over the years, which was in the end closed. Yeah. But yes, where the thresholds are and how long these processes take. I mean, it is a legal process that the CQC has to go through in order to take that kind of enforcement action. So I guess they're not going to do that unless they've got a whole host of things sort of lined up, if you see what I mean. So
okay, thank you.
Just from previously attending this CCG meetings, the same is true in primary care with GP practices. Many of them haven't had a CQC inspection since 2015 or 2018. That's quite common. But it is more of a concern in adult social care, when the ability of service users to raise concerns to us is more limited. And I agree with those points.
Well, any social care service which is rated as inadequate will be getting attention from the CQC. It's in what's called special measures at that point in time. So that they're not now being left to their own devices as such.
Yeah. Okay, thank you for that. And I understand, just following on, Ruth, you have a community pharmacy service update.
Yeah, there haven't been so many community pharmacy change notifications since the last steering group. The most notable one, which you might have seen in the media, is that Superdrug from Hertford Street is moving into the lower precinct. So they have to move because that's one of the buildings that's being demolished in the new scheme that's coming in for that end of town. So I haven't seen the outcome actually. So they have to actually apply to NHS England in order to move their NHS pharmacy services. So that has gone in, but I haven't seen an outcome of it. It's not the kind of change where we can actually say anything about it. There's only certain kinds of change applications where we could say something from a Healthwatch point of view, and there's been a couple of other change of ownerships of pharmacies in different places around Coventry. And the final thing is that the pharmaceutical needs assessment document, which is produced every couple of years and kind of sits under the remit of the Health and Wellbeing Board. So that's been published now for Coventry and Warwickshire. So it's a kind of sense check, checking what pharmacy services are available for local populations and trying to take a view on whether that meets the need and the sort of national framework around it. So it kind of concludes by and large that pharmacy provision is still adequate for the population's needs in Coventry. But there are less pharmacies and a contraction in opening hours compared with the last time it was done.
Okay, so I think that just about covers off everything, unless anybody has any other points to raise. We've got some for information items and further reading, which the team have kindly included, and that includes a guide for how to make GP websites more usable and accessible, a document called People First, which is a response from health and care leaders to the urgent and emergency care system crisis that's been published by the CQC, and also a King's Fund paper on building capacity and capability in adult social care, which will be highly relevant to a lot of the things we've discussed today, I suspect. Any other business? Does anybody have any points to raise? Ruth, I see you've unmuted. No, okay. I noticed that NHS England were doing a conference, an online conference on November the 24th called Start With People. And it's aimed at anybody in health and social care. And it's about engaging with people and communities. I think they'll be presenting on some of their strategy there. So might be of interest to the group potentially. And I could try post a link around. Okay.
Is that for anybody to go to, Ed, or is it?
I'm just checking online.
Because sometimes Healthwatch England send around things like that. I know it's not something that kind of rings a bell, but I might have a backlog in my inbox.
Yeah, I will double check. It appears to be open to anybody, but it's not always
Send
clear.
it to me and I'll investigate. Yeah. So.
Yeah, it's not always clear, is it? Just something that I saw on social media the other day.
Yeah, I mean, there has been a big drive coming from NHS England to actually work more with communities, and the whole kind of strategy and good practice documents for ICB that came out a while ago. Can I just add to that it's Healthwatch Week coming up in November. Maybe one of the team will know what dates it is. So Vizzy's emailed around to steering group members if you want to go to any of the sessions. I think you've had the kind of summary sheet, but if you want to know more about what those sessions are about, we have access to that information and can send it to you. It's not a whole week anymore, it's 3 days. But it's also used as an opportunity to promote Healthwatch, and the Healthwatch network that week is as well, to try and raise our profile. So we have one remaining steering group meeting left in our diaries, which is the 6th of December. So we need to think about setting some dates into next year. So Rizzy will be in touch with some options, so please reply to her. And the other thing, which actually is an item of any other business, because I thought the agenda, is we are recruiting for new steering group members at the moment, because the steering group is sort of really at the centre of Healthwatch. It needs to be at the centre, and it's about how local people are involved and involved in kind of setting the direction for Healthwatch. So we've got recruitment materials, and there'll be some stuff coming around as well. So pass on information in any way that you can to any people. And certainly you can see from the agenda today that there's a lot of issues, isn't there? And there's a lot of challenges for health and social care, and a lot of change going on in terms of the local structures and the things that Rose was speeding through, some of which we understand and some of which we don't at the moment, and that's absolutely fine, because we are lay people. We're not part of the professionals, but we're here to provide this kind of challenge and this different perspective.
I don't think you and Ed are lay people anymore, Ruth.
I like to hold on to the fact that I'm a lay person, because I'm not an NHS manager and I'm not a clinician. I've never done either of those roles, and yeah, but there's a fair few things that hit my inbox, and I'm reading it and thinking, I don't understand this, because I'm not off in the kind of world where all these conversations have been happening at the moment. So, and I think it's important actually, and it's fine for us to ask the questions. It's fine for us not to know. It's just like it, and I always think that means that things need to be explained differently. So it's not our problem. It's like, so, because for Healthwatch to function, it's the ground up, isn't it? It's about real people and how we interface with the people who run and plan the services, and they would like it if we all just talked their language and became sort of a bit like them, but we're not, we're people. So anyway, that's my sales pitch. So,
when I started attending these meetings, I was a lay person, and I think Healthwatch has transformed me into something else. So
Oh dear.
I don't know what that tells you.
None of us not in it.
But yeah, no, I agree. It's really important to consider these things, and if you're not doing that in policy making, you're not doing good policy. All the best ICB, ICS chairs are plugged into this, and we need to keep driving at them to consider people's views and not just consider the finances and the data and the managerial considerations.
And actually, to hear from people, to talk to people, and to understand people's experiences or get their views, they have to do that differently, and they have to resource it as well. And otherwise, it gets caught in this loop, really, doesn't it? In terms of exercises take place, but in reality, do they actually learn any more? If you see what I mean. So I mean, there's some things that have been on the agenda today which don't fulfil our good engagement principles, as they're now called. So having a survey that's out for a week and a half, for example, about dermatology services, well, that what will that achieve, really? And I'm quite concerned about that, really, and that's being taken forward as an approach after all the conversations that we've had about those kinds of things. So always more to be done.
Yes, and yeah, I think we need to just underscore to these people, if you are listening to and engaging with people, it will save you money. Ultimately, it's not good to run around fighting fires and wasting resources in that way. So yeah, that's all I have to say on that. I think that's everything then, unless anybody has any further comments. We'll wrap it up there. Thank you all for attending today and contributing to the discussion. Yeah, enjoy the rest of your day.
Yeah, and hope to see you all back face to face in December. And it's the to Christmas, so I think how we can lure you with Christmas things as well. So, all right, take care, everybody. Thank you.